Uh, can you see my slides?
Yes, Nirmal, you're
Yeah.
audible and you're visible.
Yeah. Okay. So I'm now going to present the real world data of MET amplification. So yeah, this was a 52-year-old female who was a never smoker, evaluated for dyspnea and cough. Chest X-ray suggestive of left pleural effusion. Pleural fluid cytology was suggestive of metastatic adenoCA. Whole body CT scan was suggestive of isolated pleural effusion, no visceral METs. Next generation sequencing on the pleural fluid cell block showed MET copy number of 3.10 with respect to 2.0 for wild type cells, suggestive of MET amplification. So this was the scans of the patient. There was this pleural effusion, which was the only site. So isolated pleural effusion and this MET exon copy number of 3.02. Uh, yeah. So with this, how would you treat this patient with chemotherapy, with immunotherapy plus or minus chemotherapy or targeted therapy? What we did was we started this patient on crizotinib. Crizotinib was started in the dose of 250 milligrams per day, twice a day for 2 months. But the PET scan showed new development of ascites and peritoneal mets. So crizotinib clearly did not work. So we changed this patient to chemotherapy, which consists of pemetrexed and carboplatin, which was given for 6 cycles, and there was some partial response. So what next? What next would you do? Would you observe this patient? Would you give pemetrexed maintenance for 1 year, or would you give targeted therapy for MET inhibitor? Okay. So as Dr. Anuradha pointed out this CMET pathway, so we have different CMET inhibitors, class 1, class 2, which Dr. Ullas did alluded to. So we chose capmatinib based on the IC50 value, which was the least for this. So IC50 value of capmatinib is 0.6 as compared to others, which is greater. Like crizotinib is 22.5, cabozantinib is 7.2, tepotinib is 3.0, and savlotinib is 2.1, while capmatinib is 0.6. So we wrote to we wrote to Novartis for the compassionate access program, and they were compassionate enough to give us the drugs. And with that, capmatinib was started 400 mg BD, and you can see this PET scans which show the pleural effusion is gone. The ascites and peritoneal mets have also gone. There was bilateral pedal edema, which was the only side effect that this patient had, but it does not require any dose reduction or any dose interruption. So these were the scans of the patient, which showed that the pleural effusion has completely gone, and even the peritoneal and the ascites has also completely gone. So this a case of carcinoma lung, which was post chemotherapy and target therapy, treated with capmatinib, where um, this patient was showing no evidence of disease. So, this is a real life incidence where crizotinib has not worked. Even the chemotherapy had shown a partial response, but this patient was put on a maintenance capmatinib, and that is why this patient showed very good response to targeted therapy. This was another case. This was published in the IGMPO as a case report where EGFR and MET were together present de novo at the same time as EGFR. So this patient was started on EGFR inhibitors when EGFR was detected by PCR, and this patient was started on geftinib. So after 15 days, the patient had classical dyspnea, and so we got her admitted, and our protocol is to do NGS at all the patients at baseline. So when this patient had came to us, we had sent her NGS for at baseline, and we found that in 15 days we got the NGS report, which showed that EGFR and MET were coexisting. So there was this unique case where EGFR and MET exon 14 were coexisting in the same case. And then so as you can see in the scans initially, this was at baseline. Then after 15 days with geftinib, there was disease progression And then after 3 months of geftinib and capmatinib, this patient had regression. And this patient also had some paranoia and skin rash, which was because of geftinib. So we converted this patient to osimertinib plus capmatinib, and this patient is still working well. Um, yeah, so with NGS now available to us, uh, choosing the therapy has become as easy as playing some chess. As you can see, when you have exon 19 or 21 mutation, you put up forward geftinib. When you have T790, you put forward osimertinib. And when you have a MET amplification, you put forward osimertinib plus capmatinib. Yeah. Okay. So with that, I would like to end my real life experience with MET inhibitors and over to the presenters.